Hello, everyone. Welcome to our Thursday webinar series. My name is Lourdes. I am the Director of Patient Services at the Cholangiocarcinoma Foundation, and we are happy to have you here today. I'm going to just wait a little bit for individuals to get connected, have their audio set up. Today's webinar is brought to you by the Allan Bloom Memorial Fund. Allan Bloom was diagnosed with cholangiocarcinoma in December 2020. Allan's doctors started him on immunotherapy almost immediately as part of his treatment, and this treatment helped immensely. Doctors and the Bloom family credit immunotherapy for allowing Allan to surpass his initial life expectancy and live a full life even toward the end. Thank you to his wife, Jamie, and his children who have joined us on this webinar today for their continued support of the Cholangiocarcinoma Foundation. It is my pleasure to introduce Dr. Haley Ellis. Haley is a clinician, scientist, and medical oncologist specializing in biliary cancers at Massachusetts General Hospital in Boston, Massachusetts. She is passionate about helping patients and families facing cholangiocarcinoma. Thank you again for being here with us today and sharing on this topic.
Thank you, Lourdes, and to Allan Bloom's family and the Cholangiocarcinoma Foundation for this kind invitation to present on what is a very exciting and rapidly evolving topic, and that is immunotherapy in cholangiocarcinoma. I have no disclosures. Immunotherapy is a huge and complicated topic, so I will do my best to cover some of the highlights in a short time frame, and we'll break it down from the beginning. So first, we'll start with diving into the basics of our immune system, then discussing what immunotherapy is and various strategies we can use to harness the immune system to fight cancer. So before talking about immunotherapy, it's important to have a basic understanding of how our immune system works in normal situations and how it launches an immune response, and how cancer is able to hide from our immune system. Your immune system is a complex network of organs, tissues, cells, and molecules that work together to defend our body against things like bacteria, viruses, and other foreign substances. A critical aspect of the immune system is its ability to tell the difference between what belongs in the body and what doesn't. So what is self and what is not self. For example, during an infection, there are danger signals that arise from viruses, bacteria, and damaged cells that indicate the presence of a potential threat, and this can trigger a specific immune response against molecules that seem out of the ordinary to the immune system, and these are called antigens. How does our body initiate an immune response? So infected cells and even cancer cells often contain foreign molecules, these are called antigens, that are not normally present on healthy cells. So these antigen-presenting cells can patrol the body for these antigens and collect them as signs that a molecule does not belong in the body. Antigen-presenting cells then travel to the closest lymph nodes, and there they present these antigens, this evidence of a potential threat, to T cells. And T cells are the warriors of the immune system, and you'll hear about them a lot today. You have billions of T cells in your body that are able to recognize different antigens, so they are prepared for just about every threat. If T cells recognize a threat, then they become activated or woken up by these antigen-presenting cells through go signals. They can then multiply into an army and head out to hunt for the threat and launch an attack to eliminate it. How is cancer able to evade the immune system? So unlike the situation with harmful bacteria or viruses, which carry a variety of antigens that are easily recognized by the immune system, cancer can be a bit more difficult for the immune system to identify as foreign. And this is because cancer cells actually evolve from normal cells when they become altered to grow and multiply out of control. And this avoidance of immune detection and destruction is a hallmark of cancer. So that's where immunotherapy comes in. These types of treatments have existed for many years, but really it's been over the last decade that immunotherapy has revolutionized and transformed the treatments and outcomes of many cancers, including melanoma, lung cancer, kidney cancer. To highlight, one of the major strategies in cancer immunotherapy is called checkpoint blockade, which we'll talk about. And this won the Nobel Prize in 2018. So there's clearly something good here. But what about cholangiocarcinoma? What exactly is immunotherapy? So these are types of cancer treatments that harness a patient's own immune system to help fight cancer. There are a number of ways in which immunotherapy works with the immune system. Cancer cells can often produce abnormal molecules that can act as antigens, identifying these cells as threats and triggering an immune response. But these natural immune responses are usually weak and they're not fully sufficient to be able to completely eliminate the cancer. So one way immunotherapy can work is by boosting any existing immune responses against cancer. It can also trigger new immune responses to cancer, or we can even add cancer-fighting immune components to the body. So given the success that we've seen with immunotherapy in many of these other cancers, why has immunotherapy historically been challenging to use in cholangiocarcinoma? There's this concept called immunologically cold and hot tumors, and this has to do with the level of immune cells infiltrating the tumor and the amount of immune-stimulating molecules present in a tumor. A cold tumor has less immune cells and therefore is usually less responsive to immunotherapy. And there's a huge interest in how do we make these cold tumors hot? Another explanation for this might be tumor heterogeneity, meaning that different patients and even different tumors within the same patient can have very distinct molecular profiles. And these stark differences in genetics and immunology can affect how the immune system recognizes and responds to cancer. The tumor microenvironment is important to responses to immunotherapy. This is the neighborhood that the tumor lives in, which is filled with both nutrients that support growth, as well as other competing factors that are trying to fight against the tumor. And in cholangiocarcinoma, this tumor microenvironment often contains immunosuppressive factors, which limit the activity of immune cells. And interestingly and frustratingly, nearly 75% of these tumors are what's called stromal tissue. And this is the part of the tumor microenvironment that includes very supportive tissues surrounding the tumor, like connective tissue, blood vessels, other cells. And this acts as both a physical and biochemical barrier to prevent immune cells and immunotherapy from penetrating into the tumor. And this high percentage of stromal tissue is among the highest of any cancer type. And finally, we don't yet have well-defined biomarkers to reliably identify who will respond to immunotherapy. In other tumors, there are markers like PD-L1 that are somewhat useful, but there's a lot of caveats to that, and this hasn't totally borne out in cholangiocarcinoma yet. But as you'll come to see, we're making a lot of advances in this space. So now we'll move on to discussing some specific cancer immunotherapy strategies. And the first one we'll talk about is the most commonly used and well-studied in cholangiocarcinoma, and that is immune checkpoint blockade. And this was the Nobel Prize winning research. So what are immune checkpoints? These are the brakes of the immune system. The common ones you'll hear about are CTLA-4 and PD-1, PD-L1. These play a key role in slowing down the immune reactions to keep them under control, helping to keep the immune system from attacking normal, healthy cells, and restoring order after there's been a strong immune response to a threat that has been eliminated. And while these checkpoints can serve as important safety mechanisms, in some cases, they can actually slow down desirable immune responses too soon. So the immune system may be able to recognize that cancer cells are dangerous and don't belong in the body, but checkpoints can slow the immune cells down before they're able to attack and kill a tumor that's forming. A growing tumor can even take advantage of these checkpoints to defend itself against these attacking warrior T cells by producing these checkpoints. So that presses the brakes on these warrior T cells and slows down their activity from fighting the cancer. How does this specific checkpoint CTLA-4 work? As these T cells recognize a threat, they become activated and they receive go signals from an antigen-presenting cell, that cell that's sort of patrolling the body looking for foreign molecules. However, the T cells begin to resist this activation by producing this CTLA-4 checkpoint. And while this checkpoint looks very similar to the go signal, it actually delivers a stop signal. So there's this checks and balances between stop and go signals. And if the stop signals outweigh the go signals, T cell activation slows down, and this minimizes their ability to go attack any potentially threatening cells. The other checkpoint that I mentioned, PD-1, PD-L1, there's an interaction between the PD-L1, which is on tumors, and the PD-1 on the surface of T cells that puts a brake and inactivates these T cells, which causes them to become exhausted or dysfunctional, and they stop attacking the cancer cells. Cancers can hijack this safety mechanism and prevent T cells from doing their job of killing cancer cells. And they can often produce a lot of PD-L1, and this stops the invading T cells from attacking the cancer and allows the cancer to escape the immune system. How does checkpoint blockade, this type of immunotherapy, work? So this takes the brakes off the immune system, which increases activation of the immune system and helps it recognize and attack cancer cells. CTLA-4 checkpoint blockade prevents that CTLA-4 checkpoint from sending any of those stop signals. So the go signals triumph, and then the T cells become more activated to launch a strong attack on cancer cells. And a well-known CTLA-4 inhibitor that we use is called ipilimumab or Yervoy. PD-1, PD-L1 checkpoint blockade prevents T cells from becoming dysfunctional, and it can even reinvigorate those dysfunctional T cells to attack the cancer again. And there's a number of checkpoint inhibitors that block these checkpoints called nivolumab, pembrolizumab, and durvalumab. So let's talk about some specific situations where we can use immune checkpoint blockade drugs. Microsatellite instability high, MSIH, or deficient mismatch repair, DMMR, tumors have an altered DNA repair system. So they're prone to making errors during DNA replication, and that leads to a high number of genetic mutations in these cancer cells, which can stimulate the anti-tumor response and often improves outcomes to immunotherapy. This isn't a terribly common biomarker we see in biliary cancers. It's in about 1 to 5%. And we can find these MSI high and mismatch repair deficient tumors by looking for them in the tumor and or the blood. Most cholangiocarcinoma tumors are microsatellite stable. So there really aren't a lot of mutations present in most of these tumors. But importantly, for these patients that do have this biomarker, pembrolizumab or Keytruda is FDA approved in all solid tumors with this MSI high mismatch repair deficient biomarker. And this was actually the first, what we call tumor agnostic indication, meaning it doesn't matter where the tumor is located. If the tumor has all of these mutations, we would reach for immunotherapy. And there are many incredible examples in both early stage and even advanced cancers of curing people with an immunotherapy alone who have these MSI high tumors. So it's so critical to find these people. Another setting for immune checkpoint blockade is in what's called tumor mutational burden high tumors. TMB, tumor mutational burden, is a biomarker that reflects the number of mutations present per megabase of DNA. So it's in mutations per megabase. The cutoff by which we determine what is TMB high is a little bit controversial, but TMB high refers to there being a high number of mutations in cancer cells, which can lead to the production of abnormal proteins that may be recognized by the immune system and potentially makes the cancer more sensitive to immunotherapy. Though there's often overlap, MSI high mismatch repair deficient tumors are often also TMB high. That is not always the case, and there are definitely tumors that are TMB high only. Again, this is a rare biomarker in biliary cancers, but biomarker testing, as CCF highlights, is so important. And pembrolizumab is also an FDA-approved option for people with these tumors. So outside of these rare biomarkers that we just talked about, the MSI high and TMB high, one immune checkpoint blockade drug on its own has a pretty limited role in cholangiocarcinoma. So now we need to look at how do we combine immune checkpoint blockade with other types of treatments. So in advanced cholangiocarcinoma, we now have 2 completed phase 3 trials that have established a survival benefit, though modest, with the combination of gemcitabine cisplatin chemotherapy with PD-1 checkpoint blockade. The TOPAZ-1 trial, which looked at durvalumab or Imfinzi with chemo, led to the first cholangiocarcinoma-specific immunotherapy approval in 2022, and it now represents our new standard of care for treating patients in the first-line setting. Keynote 966 was a more recent study that provided further evidence and confirmation of the benefit of adding immune checkpoint blockade to chemotherapy. And whenever we see good effect of treatment in the advanced setting, we try to bring it forward earlier in treatment. So now there are trials evaluating these combinations in patients who are eligible for surgery before and after the surgery itself. So this is called neoadjuvant or adjuvant therapy, before and after surgery. So this data is from the TOPAZ-1 trial I just mentioned, which compared gemcitabine cisplatin with and without durvalumab, which is that PD-1 checkpoint blockade. Interestingly, though the median survival benefit is modest, the benefit appears to improve over time. So if you look here at the tail of these survival curves, you see more than a doubling of overall survival noted at 2 years in the patients who got immunotherapy. Subgroup analysis suggested that maybe there's a greater benefit for patients from Asia. There might be a number of reasons why this is the case. Intrahepatic cholangiocarcinoma and those with a recurrent disease instead of upfront advanced disease, although these results should be interpreted with caution as these statistics were not powered to make these calls. But there's clearly a certain subset of patients that really do benefit from this combination. And so this leaves a lot of questions like, who are the long-term responders? Can we find tumor or patient-specific factors that function as biomarkers of response and resistance? What do we do with continuing chemotherapy? Both these trials were slightly different in what they did with the chemotherapy. What do we do after people progress on immunotherapy? Should we continue immunotherapy in the next line? So these are all questions that we're working on answering. An example of immune checkpoint blockade in combination with targeted therapy, which is another type of treatment that goes everywhere in the body and can attack these biomarkers that we find, is in IDH1 mutant cholangiocarcinoma. This is a mutation we see in up to 20% of intrahepatic cholangiocarcinoma. And we know, and this is work that was done in the Bardisi lab, that IDH1 mutations promote an immunosuppressive T-cell excluded environment. In this image on the right, the bottom row, the brown staining is for T cells. So you can see if you're comparing the left side, which is no IDH1 mutation, to the right side, which has the IDH1 mutation, there's hardly any T cells in these mutant tumors. So these are the immunologically cold tumors. But when we combine ivosidenib or Tibsovo, which is the IDH1 inhibitor, with an immune checkpoint blockade, CTLA-4, it resulted in dramatic tumor shrinkage in preclinical models. And this is actually the basis for a clinical trial that's recently started. Another combination with immunotherapy is treatments that are related to blood vessel formation. Angiogenesis is the process of forming new blood vessels from pre-existing ones. As you can imagine, this is important in cancer where tumors need a blood supply for nutrients and oxygen to grow and spread. VEGF, VEGF, is a protein that stimulates blood vessel production, and we can block VEGF with targeted treatments. And by doing so, we're essentially trying to cut off the blood supply and the nutrients that the tumor needs to grow. Preclinical studies suggest that VEGF is immunosuppressive. So what happens when we combine it with immunotherapy? These combos are standard in kidney cancer, for example. There was a phase 2 study of a drug called lenvatinib, which is an anti-angiogenic drug, so a blood vessel blocking drug, and pembrolizumab, an immune checkpoint blockade. And it showed promising anti-tumor activity in patients who had prior treatments with advanced biliary cancers. And this is now actually part of our NCCN guidelines in patients who haven't had prior immunotherapy. There's an ongoing phase 2 trial of a drug that's actually a dual immune checkpoint blockade, plus or minus these VEGF targeted treatments. Shifting gears to combine immune checkpoint blockade with a local therapy, radiation. So this example actually isn't in cholangiocarcinoma, but I think it highlights a really important point. This is looking at how radiation enhances immunotherapy response in colorectal and pancreas cancer in tumors that are microsatellite stable. So again, those are those common tumors that have not very many tumor mutations. And the idea with this strategy by giving radiation immunotherapy is that you increase the likelihood of having a systemic response to immunotherapy by what we call the abscopal effect. So by treating a tumor locally, that leads to anti-tumor response at distant sites that did not have radiation. And in this example here in the scans, This patient had multiple lung metastases that responded and shrunk after radiation treatment of the lesion in the liver when they also received dual immune checkpoint blockade. And these are strategies that are also being tested in clinical trials in cholangiocarcinoma. So moving on from immune checkpoint blockade, which is currently the richest area of immunotherapy strategies in cholangiocarcinoma, we'll talk about agonist antibodies. These are similar to natural antibodies in some ways, though they are engineered or modified to enhance their activity and specificity for their immune targets. CD40 is a molecule that acts like a key that unlocks the door to a strong immune response. So it stimulates those antigen-presenting cells that are patrolling the body looking for foreign threats. Immune cell activation by a CD40 agonist enhances the response to PD-1 checkpoint blockade in preclinical studies in cholangiocarcinoma. And this efficacy can be further improved with cholangiocarcinoma. So in this graph, the light blue line on the far right is showing that the combination of chemo, a CD40 agonist antibody, and PD-1 blockade results in superior survival. And this data is the basis for a new trial studying CAPOX chemotherapy plus a CD40 agonist antibody plus pembrolizumab or Keytruda in refractory advanced biliary cancer, which is very exciting. CD27 is like a communication device that helps immune cells work together. There was a phase 2 trial in metastatic biliary cancer of atezolizumab. This is a different type of immune checkpoint blockade, plus or minus this drug called cobimetinib. This is a drug that blocks growth signaling, and this combination doubled progression-free survival. And there's actually durable responses that have been ongoing for more than 2 years. And so now there's a trial that's looking at how do we further boost this strong immune response by adding a CD27 agonist to this combination of immune checkpoint blockade and a targeted therapy. Another novel area is cancer vaccines, which hasn't come full force in cholangiocarcinoma yet, but certainly an exciting area for the future. One comment I should make is that in general, outside of the HPV vaccine, which can prevent HPV-related cancers, these cancer vaccines we're talking about are not preventative per se, but act in a way to trigger an immune response in someone who already has cancer. So like vaccines that protect us against infections, vaccines that treat cancer work by introducing cancer to the immune system in a way that triggers a strong immune response. And so developing these cancer vaccines is usually a personalized process that involves identifying and selecting these antigen molecules that are unique to a patient's cancer, meaning they're not found in normal healthy cells in the body and can be readily recognized by the immune system. And these antigens then get incorporated into a vaccine and delivered to patients. There's a bunch of different strategies on how do you best select these antigens for a vaccine, but one really exciting area is what's called neoantigens. These arise when mutations in the cancer cells cause them to produce a mutated protein that is entirely new to the body and looks unfamiliar to the immune system. And unlike antigens that are part of the tumor, these proteins are not in any normal or healthy cells, so they stand out to the immune system as not self. So these are great targets for a vaccine. And a really exciting recent example is actually in pancreas cancer, which is another immunologically cold, challenging to treat cancer, where they developed a personalized neoantigen vaccine that was given in combination with immune checkpoint blockade and chemo, and showed that this combination delayed the recurrence of pancreas cancer after surgery. The next thing that I'll mention is cellular therapies. People are always very excited to hear about CAR T cells, which have proven highly effective in blood cancers, though have been a bit more challenging to implement in solid tumors, though there's a lot of exciting efforts happening, even in cholangiocarcinoma. How this works is that we collect T cells from a patient's blood. We genetically engineer the T cells in the lab to express what's called a CAR, a chimeric antigen receptor, on the surface of these cells. And these are designed to recognize a specific marker on the surface of cancer cells. You then expand and activate these genetically engineered T cells in the lab so that you have enough to inject back into the patient, and you're boosting their anti-tumor activity. And then you infuse the CAR T cells back into a patient's blood, and the CAR T cells migrate to the tumor site, recognizing kill cancer cells expressing this target antigen. So cool. So there's a number of potential targets in cholangiocarcinoma that have been explored, which are listed here. And this is an ongoing area of research. Another example of cellular therapies are called tumor-infiltrating lymphocytes, or TILs. These are a subset of immune cells that migrate from the bloodstream into the tumor microenvironment. And in somewhat of a similar fashion to how we generate CAR T cells, we're able to harvest these TILs from tumor tissue, so it's usually a surgical procedure. You can then expand and activate TILs in the lab to enhance their ability to recognize and kill cancer cells. The patient will then get what's called conditioning chemotherapy, and that's really to make space in the body for these TILs and reduce the population of suppressive immune cells that could limit their function. And then the last step is reinfusing TILs into the patient so that they traffic to the tumor. They're able to recognize these cancer cells expressing tumor-specific markers, and they can mount an anti-tumor immune response to eliminate the tumor. And I'll finish with an example, which is a really nice highlight of cellular therapies. So this was a 41-year-old who was diagnosed with cholangiocarcinoma. She had a liver resection. Unfortunately, as we often see, the cancer quickly recurred with multiple metastases in the liver and lungs. She had a couple rounds of chemotherapy, though the cancer progressed through it. Chemo was by no means easy, and after 18 months with diminishing quality, she ultimately decided to enroll on an experimental clinical trial of TIL therapy. So again, they were able to surgically remove a piece of the tumor, they separate out the immune cells, expand them in the lab, and they were able to find this population of immune cells that responded to one particular mutation that distinguished the tumor cells from the healthy cells. They delivered a dose of over 40 billion T cells, about a quarter of which were specific for that mutation, and the tumors regressed. After several months, the tumors in the lungs grew again, and to better understand how that treatment initially worked and why it eventually got outsmarted, the team took more blood and tumor samples and found that many of those mutation-specific T cells that they had used to treat this patient were still present, and the tumor still expressed this targeted mutation. So the patient got a second dose of now more than 100 billion T cells, almost all of which now were specific for that one mutation. And once again, the tumors began to rapidly and dramatically shrink. And after this trial closed, her disease remained stable for a couple of years before she required an additional surgery where they found high levels of a biomarker called PD-L1. And this led to treatment with an immune checkpoint blocker. And she is now 14 years from her original diagnosis. And for those of you who don't know, this is the remarkable story of Cholangiocarcinoma Foundation's very own Melinda Bikini. And her courage and those billions of T cells certainly changed the course of her life and scientific research, but has also led her to helping countless others through her incredible patient advocacy. So where do we go from here? There's clearly a signal that immunotherapy can work in cholangiocarcinoma. And I think what will be critical is better selecting patients for specific strategies. So being able to find biomarkers of response and resistance, understanding what do we do after tumors have grown on immunotherapy, what do those next treatments look like? And I do think, and certainly efforts are already underway with vaccines and cellular therapies, but I think we'll see an increasing role of immunotherapy beyond just immune checkpoint blockade. And some common things that I just have to finish with that extends across all our efforts in cholangiocarcinoma and certainly with immunotherapy is that clinical trials remain vital for advancing care, and the importance of science-driven trials through bench to bedside and bedside to bench, that cycle of research. If you saw, many of the trials I mentioned are based on work being done in the lab studying cholangiocarcinoma, and this helps us design better and better treatments for the future. So special thanks again to the Allan Bloom Memorial Fund for supporting this important educational webinar. The Cholangiocarcinoma Foundation's message of strength in community hope and research is put into action every day by people all around the world. But I will give a special shout out to both the Bardisi Lab and the Boston Care team. I love working with and learning from all of them in our shared goal of making a positive difference for patients and loved ones facing cholangiocarcinoma. So thank you so much, and I'm happy to take questions.
Thank you so much for this presentation. To the community, everyone who's watching, if you do have questions, please feel free to put them into the Q&A or into the chat. Please remember to keep your questions as general as possible, as Dr. Ellis cannot answer specific questions. Somebody is asking if it's worth switching from Imfinzi to Keytruda if there are MSI high and DMMR.
That's a good question. I think it probably depends on what the status of the tumor is currently. Is it responding to Keytruda, where there would be or responding to Imfinzi, where there would be a thought to switch to Keytruda? Certainly
if
these
the
molecules,
tumors are reducing in size.
if the tumors are reducing in size, then I would stay the course. That's fantastic to have that response. And again, such a win to find patients who can benefit from just a single immunotherapy drug with MSI high tumors.
Do any of these particular therapies work well with extrahepatic non-resectable tumors?
Great question. So in the 2 upfront trials that I mentioned, where they were looking at the combination of chemotherapy and PD-1 immune checkpoint blockade, there was not a worse outcome with extrahepatic cholangiocarcinoma. And certainly the mutational profiles of intrahepatic versus extrahepatic cholangiocarcinoma versus gallbladder cancer are different. So I think perhaps there will be different strategies that are needed, but we absolutely have seen promising results with tumors beyond intrahepatic cholangio.
Do you know anything about the vaccinia CF33?
I don't, but I'm happy to look it up and get back to you.
Okay. Do you have an opinion on what TMB makes sense for immunotherapy?
Great question. So the label for that pembrolizumab Keytruda approval in TMB high all solid tumors is more than 10 mutations per megabase. That cutoff was based on other types of tumors like lung cancer. I would say that in cholangiocarcinoma, which again is a more immunologically cold tumor, I would hope that number would be a bit higher, but certainly by the label, more than 10 is the answer. But oftentimes when we see truly TMB high tumors, these are in, the 20s and 30s, or even higher, much higher.
Do you know what range is considered MSI low versus MSI high?
Every test is a little bit different. So it might be done by what's called an immunohistochemistry test or a next-gen sequencing test. And it would just be important on a biomarker report to see what they use as their cutoff. But certainly in all gastrointestinal cancers, essentially now, they're testing this routinely. And pathologists, particularly at a big academic center, are very experienced in determining what is microsatellite stable versus MSI high.
Okay. Can you expand just a little on the TMB high numbers? What is considered high?
So I think, as I said, the technical cutoff is 10, but there isn't anything specifically in cholangiocarcinoma, so it's a little bit up for debate.
Okay. Is immunotherapy being used in combination with second-line chemo?
Off-label, yes. There are, studies looking at answering that question, and I think certainly a lot of us, if people have a good response to immunotherapy in the first-line setting, we're very keen to continue that, even if we change to a different chemotherapy. Is there cold hard evidence yet? No, but I think anecdotally we're seeing some good responses.
Okay. Do you know if there's any immunotherapy that is working for FGFR2 fusions?
Very exciting question. So I believe there's a study actually going on in Germany right now, looking at combining FGFR inhibitors with immunotherapy. There are specific isoforms of FGFR. There are 4 different types that sit on the surface of the cell that have a very immune-involved role. So I think it makes a lot of scientific sense to combine some of those pan-FGFR inhibitors that are targeting all the versions of FGFR that sit on the surface with immunotherapy. So this is definitely something that I think will become standard in the future.
This is a thank you, a shout out to you. They want to thank you for today's presentation, but also for the lab tour in Boston. She was present for patients and caregivers last month. That you give
You are
us
so
all
welcome.
hope. If Tibsovo is working but not reducing the tumor size, is adding in another therapy going to become more accepted?
So this is a great question, and this is exactly the basis of that new clinical trial that's now open. We know that when you give Tibsovo by itself, eventually there's sort of changes in the immune microenvironment that makes it not work anymore or for a short period of time. So combining it with immunotherapy, with immune checkpoint blockade in mouse models has proven to be dramatically successful. So I'll be very eager to see the results of this clinical trial. But I do think, as we've seen in other cancers, combining immunotherapy and targeted therapy in certain scenarios makes a lot of sense. So I do think this is probably the way of the future.
If someone was newly diagnosed as stage 1B, but they didn't mention immunotherapy, would you maybe suggest asking about it?
So I think now with there being trials available where they're looking at combining chemotherapy and immunotherapy prior to, I would imagine, being considered for a surgical resection with a stage 1B tumor. If someone is interested in a trial like that, the data is very promising, certainly in the advanced setting, and we're looking to see, does adding immunotherapy before surgery make a difference? So that would be done in a clinical trial setting.
Can you combine immunotherapies after you stop chemo?
Yes. So there is an approval for combining ipilimumab and nivolumab. So these are 2 immune checkpoint blockade drugs. Again, the best responses are probably seen in tumors that have that MSI high or TMB high biomarkers. But that is part of our NCCN guidelines now.
Okay. Do you know anything about the MRTX 1719 drug?
Is that a KRAS inhibitor, Murati? Oh, it's the PRMT5 inhibitor. So yeah, this is a really exciting area that's been seen preclinically, and certainly the scientific rationale makes a lot of sense to give tumors that have certain biomarkers a PRMT5 inhibitor, and this would be tumors that have MTAP loss. So again, no definitive data yet, but the clinical trials are ongoing, and it's very exciting because it's a novel target that we haven't had treatments for before.
Are there any studies looking at targeting the microenvironment components which tend to support cancer growth?
Yes, there are studies that are looking at, targeting, specific tumor microenvironment features. I think that the tricky part sometimes with targeting the tumor microenvironment is just physically being able to get drugs in there. As I had mentioned, that the tumor microenvironment can be very dense and can place a huge barrier to immune cells and chemotherapy and targeted therapy and immunotherapy getting in. But I do think finding a way to sort of break through the tumor and microenvironment will be really critical to improve responses to immunotherapy.
There are a lot of questions surrounding Tibsovo. And if there is any recommended checkpoint inhibitor drug that might be used in conjunction with Tipsovo, or if there's a benefit to switching from Imfinzi to Tipsovo if that's a known mutation.
So I think our general adage for treatments is if they are working and you are tolerating it, that is a huge win, and we would keep going. If at some point the cancer started to grow on the treatment you were on, or the side effects became intolerable, then that's a time to think about switching treatment. I do think having biomarker testing done early is really helpful because it makes you sort of ready for that next step if something like Tipsovo or another targeted therapy is available. At this time, it would be difficult for insurance to approve combining an immunotherapy drug with Tipsovo, but there is a trial that's going to be nationwide that's looking at combining Tipsovo with immunotherapy.
Perfect. If someone's unable to get any biomarkers, they don't have any biomarkers after having biopsies and blood work, is there anything that you would suggest to come next? We always suggest clinical trials just in general, but
yes, indeed. So certainly because half of people with cholangiocarcinoma do not have what we call targetable biomarker, there is a huge interest in, how do we help that group of patients? And I do think there's a whole avenue of what's called biomarker agnostic trials. So where they take all types of tumors and even some very rare alterations like ARID1A, for example, which we don't have any proven targeted therapies for. But I think oftentimes in these biomarker-free spaces, that's where trying things like immunotherapy can be sort of a reasonable avenue to consider with your team.
And then along the same line of biomarkers, is it worthwhile to do another biomarker test if one was done a while ago and there were no actionable mutations?
So I think tumors under therapeutic pressure, so when they're getting a treatment, can evolve over time. So I think more information is always powerful, and getting serial biomarker testing can be very helpful to see, has the tumor changed in some way? And importantly, insurance is now much more open to sort of running these biomarker panels repeatedly. So I do think if a repeat biopsy or a liquid biopsy is something that your team considers, having more information to see if the tumors change is very helpful.
Can you explain how the radiation at one site reduces other tumors?
So the idea is this abscopal effect. So when you're radiating the liver, for example, it's releasing all of these neoantigens. So these molecules that are produced by the tumor, and that's stimulating the immune response. And the immune response is not just localized to the liver, it's localized everywhere. So the idea is that by capitalizing on sort of stirring up some of these neoantigens locally, if combining it with immunotherapy, can you try and get a response everywhere? So that's sort of the idea behind why radiating one spot can sometimes be very helpful in shrinking tumors not where you radiated.
Okay. What are some side effects of immunotherapy treatment to watch out for?
Great question. So immunotherapy is very different from chemotherapy. In general, most people feel very well on immunotherapy. But if you can imagine, the idea of immunotherapy, or specifically immune checkpoint blockade, is that you're taking the brakes off your immune system to let it run rampant. Sometimes the immune system can get overactive and stimulated and confused and start targeting normal parts of your body. So a common change that we see is what we call immune-related adverse events, where you can get inflammation in any organ of the body. Most commonly, it would be skin, where you would see things like dry, itchy skin, perhaps a rash, and that's often very well controlled with creams and topical treatments. The other thing that we watch out for is your thyroid function. Most people don't develop symptoms, but it's something that your team very likely tracks in the blood, because oftentimes the immunotherapy can make your thyroid a little bit underactive, and putting you on thyroid replacement fixes that. In rare situations, the inflammation in some of these organs can be severe, which would end up meaning high dose steroids, sometimes even ICU stays for serious things like inflammation in the lungs, inflammation in the heart. In very rare cases, it can be fatal, but we've been giving these drugs for over a decade now. So there's often whole teams that are, able to manage these side effects, and we're all very aware of what to look out for.
Can patients with autoimmune issues still use immunotherapy for treatment?
So yes, so it depends on the situation. And that's where having multidisciplinary care is so important. In a lot of situations, even if people have certain autoimmune diseases, if they've had some immune reactions before, we can often challenge them with immunotherapy and careful monitoring to see how it goes. But it's a little bit dependent on the situation, but certainly being closely linked into rheumatology or whoever is managing an autoimmune condition is very important.
Okay. When does CAR T cell therapy usually begin? Generally, is it earlier or later in treatment? Do you know?
So right now, there are no approved CAR T cell therapies in cholangiocarcinoma. So this would likely be probably more of a later line therapy, because the good news in cholangiocarcinoma is, while back in 2010, we had one treatment, now in the past 5 years, we have dozens of treatments available that we have good data for. But certainly, I think with designing better CAR T cells and picking better targets, the hope would be that it moves up earlier into people's treatment courses. And that's why clinical trials are so important, to be able to test these types of therapies to see if they help people.
Do you have any thoughts on using immunotherapy when someone also has ascites?
So I would say that's not an exclusion to getting immunotherapy. Immunotherapy, because it's an infusion that you can get either through a port or through a peripheral IV, goes everywhere in the body. So if there are cancer cells in the belly that are making this fluid, the ascites, then theoretically, the immunotherapy should be hitting those cancer cells too. So that wouldn't be an exclusion.
Okay. Do you know of any trials related to the KRAS gene that are promising at this time?
So this is a huge area of research. KRAS is a very common mutation in cholangiocarcinoma, as well as other challenging cancers like pancreas cancer. And up until a few years ago, people said it was undruggable. But now there are a number of clinical trials that are really exciting. One that I'm very interested in is what we call pan-RAS inhibitors, where it's hitting multiple different versions of KRAS. So what's tricky about some of these biomarker reports is there will be KRAS and then numbers and letters after it. And that sort of specifies exactly what type of mutation it is, what the spelling mistake is. And that's very important, those letters and numbers that come after KRAS. But some of these newer drugs are covering lots of those different, we call allele changes. And I think that's very exciting. There's KRAS targeting vaccines now, in addition to some of these targeted therapies. So I think that this is a really rapidly evolving area, which is exciting.
Are there any data that show better success rates in using specific treatments for early onset, younger than 50 patients? Or are the results of these studies agnostic in terms of demographics?
So I would say at this point, the numbers are probably too small. In general, for example, when we look at those two first-line chemoimmunotherapy trials, which were phase 3 trials in cholangiocarcinoma, there wasn't really any subgroup that, looked dramatically better or worse. A lot of the sort of subtle changes we see are not statistically significant. So at this point, I would say no, but the hope would be that with doing more trials that we're able to, look across many clinical trials and pool data to be able to answer some of those questions.
Someone is just asking what you mean by future. Like, what is there a timeline or time frame?
It's a great question. I mean, again, when I look at the pace of what's happened over the past 4 years, even since 2020, I think it's remarkable. And I do think that there's a lot of really talented researchers and clinicians interested in immunotherapy. So I expect things to move quickly. Honestly, solid tumors and tumors, particularly like cholangiocarcinoma, are sort of a tough nut to crack with things like CAR T cells and cancer vaccines. But there's a lot of really talented people working hard at it. So I hope in a short number of years, there may be some potentially very interesting clinical trial options and hopefully approved therapies down the line. But I wish I had a crystal ball.
Right. Do you have any information on nutrition and immunotherapy in combination?
So this is a really interesting question. So there's a lot of work being done looking at how the microbiome, so the different types of bacteria in your gut, play into immunotherapy responses. At this point, there's not definitive evidence one way or another, but I think it's definitely an area of research that people are looking at with the microbiome and certainly how people's diet impacts that and therefore responses to immunotherapy.
Do you know anything about the study being done at Mass General with pemigatinib and afatinib? I don't know if I said that correctly.
Yes. So that study just opened. So we're just starting to enroll patients now. So there's no data on it yet, but that was a study that was designed based on preclinical work showing that the combination of FGFR and EGFR inhibitors show better effect in sort of overcoming resistance. So we should be enrolling patients soon and hopefully we'll have data in the coming months and short years.
Perfect. Would radiation therapy after Xeloda as an additional adjuvant treatment for resected extrahepatic cancer prevent someone from receiving immunosuppressant therapies later?
Prior radiation should not be an exclusion to immunotherapy. Sometimes after people get radiation, there can be temporary elevation of liver enzymes. And sometimes we like to see blood work be normalized before starting because, as I mentioned, immunotherapy can cause inflammation in any organ, including the liver. And, that would sort of be the only sort of small caveat that I could see to potentially delaying immunotherapy a little bit, but that would probably be unusual.
Somebody's asking about ivermectin and how it has shown promise in vivo with other cancer lines. Is there anything similar to that for cholangio that you know of?
Not that I'm aware of, though I know that that's been something that's been explored in other spaces, but in cholangiocarcinoma, I'm not aware of any preclinical or clinical data.
Is immunotherapy available for post-resection with cholangiocarcinoma and HCC combined?
Tricky question. So mixed cholangiocarcinoma and HCC is sort of a rare subtype that does combine both treatments. Different from cholangiocarcinoma, where we have more clear therapies based on prior trial data. It is a little bit more challenging with those mixed type of tumors. And it really depends on sort of what the team thinks is maybe the more predominant feature. And what we often do in those situations is it's a multidisciplinary team discussion at tumor boards to decide what do we think is the best path forward? And oftentimes we end up reaching for cholangio type treatments and HCC type treatments. HCC in general is much more immune responsive than cholangiocarcinoma, but it's a tricky situation.
Okay, thank you. We are getting pretty close to time, and I want to respect your time, Dr. Alice. So any other questions that were specific to certain mutations, we will get back to you on. And I just want to remind everyone who's on the call about the cholangiocarcinoma annual conference, which is coming up in April. If you are interested in attending in person or virtually, we have that information on the website. This webinar is recorded and it will be posted on the YouTube channel, so that if you want to reference back to it, you are more than welcome to. And if anyone here is interested in funding or supporting a future webinar, please feel free to reach out to Carly Good on our staff, and we can provide her email to you as well. Thank you again for your presentation, and all of this information is greatly appreciated. And thank you all for being here today and enjoying the webinar.
Thank you so much.
You want to mention Cholangio Connect?
Yes, thank you, Emma. If anyone is interested in a peer-to-peer mentor, please turn to our Cholangio Connect mentor program. You can request a mentor if you're a patient and a caregiver. So we do have that as well. Thank you, everyone. I hope